Hello, everyone. This is Jonathan Marks from ADHD in Adults, and we're here tonight with a really meaningful presentation called Surviving the Storm, Updates and Innovations on COVID-19 and Mental Health Care. We have a moderator tonight, David Goodman. David is Assistant Professor of Psychiatry and Behavior Sciences at Johns Hopkins University School of Medicine. He's also the Director of the Adult Attention Deficit Disorder Center of Maryland. He's a Medical Director of Suburban Psychiatric Associates, and he's on the board of APSARD, the American Professional Society of ADHD and Related Disorders. And we want to thank APSARD for providing these speakers tonight. Our presenter is Greg Mattingly, MD. He's Associate Clinical Professor of Psychiatry and Psychopharmacology and an instructor at the Washington University School of Medicine in St. Louis. He's a principal investigator for the Midwest Research Group, and he, like Dr. Goodman, is a member of the Board of Directors of APSARD, the American Professional Society of ADHD and Related Disorders. And with that, I will turn it over to Dr. Goodman to begin our session.
Good evening, everyone. Thank you for taking your time, whether you're eating dinner or sitting with the kids or quietly listening to our program. We thank you for taking your time to listen to this. I know everybody's concerned about the impact of COVID on both their patients as well as your own mental health. So my good friend and international expert, Greg Mattingly, is going to walk us through an excellent slide deck with a lot of resources. So there's a lot of good information you're going to hear from him. Greg, it's all yours.
Thank you, David. So, we developed this talk saying in the current pandemic of COVID, how is COVID affecting mental health for our patients, for our clinics, and our own personal lives? What can we learn from prior pandemics, prior infections about what are the long-term outcomes? And one of the real take-homes is that mental health care needs are not just here, but mental health care needs are going to be in the future going on. One of the take-homes from one of the studies we're going to show is that mental health care in the year after someone has a contagion such as the COVID pandemic, people need even more mental health care than they need primary care health care. We're also going to talk about how do you keep your clinics alive during this period. This is stressful. It's stressful financially, it's stressful emotionally, it's stressful from a physical perspective. So how do you keep your clinics integrated, healthy, use a sense of teamwork, and then some actual just practical kind of, economic perspectives about COVID and what's going on these days as far as perspectives. So let's take a look at some studies that come out of China, the first wave of COVID. We'll compare that with Europe, we'll compare that to the United States. And if you look at the general population in China during COVID, 54% said this is having a severe or moderate psychological impact on me. Many of these people were outside of the Hubei province area, so people in Beijing, people in Shanghai, but across the country, this had an amazing emotional impact. It's very similar to what we've seen in the United States, France, Italy, Germany, Singapore, and other countries around the world. We started saying, what are the emotional impacts we tend to see? 17% were saying, I'm really struggling with depression. 30% were saying, I'm struggling with bad anxiety. 85% of the people in China were saying that I'm having to stay home 20 to 24 hours a day, very similar to what we see here in the United States. So when you think about at-home learning, you're home with your children, you're home with your family. How do we all stay healthy together when we're both worried about physical contagion, but we're having to interact in a confined space? And 75% said I'm worried about my kids, I'm worried about my husband. I'm a grocery worker, so I'm going out and working, but I'm worried about bringing it home to my family. So it was a common constraint among people in China, similar in Europe, similar in Australia, similar in Asia, and similar here in the United States. So what did we find from this study that seemed to help? The first thing they found was specific, up-to-date, accurate health information tended to help people. It decreased their anxiety levels. It decreased them decompensating into secondary depression. It decreased to domestic violence. So knowing what was going on in an accurate fashion was helpful. A little bit later, what we'll find what didn't help was too much social media. Too much social media was a triggering event. So staying overly tuned into social media was not good, but specific, up-to-date, I'm going to see what's going on. Once a day, I want an accurate source that tells me what's happening with this. The other thing they found is a sense of being able to take precautions. So being able to do things like washing your hands, wearing a face mask, even though those things don't 100% protect any of us, but those things tended to help. So I'll use the example when I saw this study. One of the things we went to very early on in my clinic, my office, is we stress the importance of hand washing. We stress the importance of wearing masks. This was before the CDC had made their guidelines, but this study showed that just psychologically, those things made a difference for our patients, made a difference for the population. So we went to this as a very early adapter within our clinic. What did we find is that these issues, very simple things like up-to-date information, wearing masks, personal hygiene, a sense of mastery, dramatically decreased stress, anxiety, and decompensating and depression. My good friend Roger McIntyre has done a study over in China where he said, let's take a look at those that have anxiety to begin with, those that tend to be somewhat vulnerable. What happens if you ping with too much social media, if you let it trigger you? So imagine you're a patient with ADHD plus anxiety for this topic. And we know that anxiety is very prevalent, especially among our female adults with ADHD. It's the most common comorbidity. So if you had an underlying predisposition to being a little ruminative, having anxiety, too much social media use dramatically increased your risk of depression, avoidance, intrusion, and hyperarousal. I can't sleep at night. I'm on edge. I'm blowing up. Hyperarousal was 20 times more likely in the individuals that had high levels of social media use. And for those people that had both hyperarousal and frequent social media use, their chance of decompensating into depression was 20 times higher than the general population. So if you think about the things we want to do, accurate information, having a sense of being able to take precautions, what are the things we want to do? We want to unplug. Don't over ruminate. Don't let yourself become triggered. Know when to turn off for your children, your family, and yourself. So let's take a look. And I said, let's take a look back at other pandemics, other infections that have spread across the world. And so you could go back to the Spanish flu of 1917, but there's a more recent pandemic that came across, and this was the SARS outbreak in 2003. It was a coronavirus, very similar to what we're dealing with now. It didn't have the influence in the United States, but it did go throughout Asia and it went throughout Canada. One of the reasons Canada went in very early lockdown is because of their experience with the SARS virus. So this was a study done in Toronto, very similar to what we might experience in St. Louis, Chicago, David, and Baltimore. This is a urban center, this is a modern city, it's an international city. So they looked at 117 SARS survivors that had been infected with the SARS coronavirus, and they did something very interesting. They measured not just the patients, but they measured their caregivers. And then they took a look at what happens, not just when you're infected, but how about 3 months after the infection, 6 months after the infection, 12 months after the infection. Up top, you'll see I drew a bar across what is considered normal functioning. So this is normal on a number of scales. This is the symptom factor 36. They asked 36 different questions about emotional symptoms, physical symptoms. And over on the right-hand side, what you'll see is patients' physical health was impacted by SARS, but their emotional impact was just as not even more impacted by SARS. So mental health outcomes were just as impacted at 3 months, 6 months, 12 months after the infection. If you go down below, how about the caregivers? Caregivers at 3 months after the infection of their loved ones, family members, we're doing fine. And so this is a husband with a wife with SARS. This is a parent with a child with SARS, is what they considered a caregiver. Physically, they're doing well, but what was not doing well on the far right-hand side? Their emotional health. At 3 months out, these people were still traumatized, they had anxiety, they had depression. So what does that mean for long-term follow-up? Over the next year, they looked at healthcare utilization, and we saw the average SARS infected with a coronavirus patient accessed 668 psychiatric follow-ups visits over the next year, compared to primary care, 470, compared to infectious disease, 196, compared to going back to a pulmonary doctor, 25. So the most prominent healthcare need in the year after the SARS COVID epidemic was mental health access. And it was more common, if you look at 666, it was as common as family practitioner, infectious disease, and pulmonary put together. What was the average number of psychiatric visits? 7 visits with the psychiatrist, numerous visits with support groups, 10 visits with the psychologist, social work, mental health. So we're going to have a multi-system approach to helping our patients as they deal with coming out of this. So any of us that have taken care of patients in quarantine, which I have, I've had patients who've been in quarantine. I had patients who are stuck in the University of Nebraska quarantine center. I've had doctors, nurses, medical students in quarantine because they contracted COVID. This will be an ongoing emotional need, not just for the now, but for the future.
Greg, let me
Go ahead.
interrupt and just ask you, because the primary care physicians, family practice physicians, are going to see a lot of these patients, and how, perhaps you'll get to it later, how are we going to make them more aware that this really is something that they need to attend to and not dismiss or minimize, since a bulk of mental health individuals seek out help from their primary care and family physicians first before they get to a psychiatrist?
Yeah, great question. So I backed up to that slide, David. As you can see here, family practice in Canada, family practice includes internal medicine. So it's primary care is the way they think of this. It was the second most common healthcare need. And I would bet that many of these patients saw those before they got into mental health. If you look at the average number of follow-up visits in family practice, it was 5.4. The average number of follow-up visits with psychiatrists is 7.3. So the family practice doctor there will likely be the gatekeeper, but helping them to understand that the gatekeeper, this is a holistic model. If people aren't doing well emotionally, they're not going to do well physically. If people give up hope, we all know what the physical outcomes are for patients who develop hopelessness. We know that if marriages and divorces blow up, and we know that our patients with ADHD are at increased risk of divorce, separation, things such as domestic violence, all of those issues impact our patients who have ADHD plus other comorbidities. So I think helping to educate, and this is, I think, our initiatives for all of us. Let's educate not just on the here and now about the need for a ventilator, but what's going to be the need for people to regain their lives. This next study was one that jumped out at me. So it was the same study, but they said, what % of people who were employed at baseline had gone back to full-time work? In a year out, what you see is only 74% of people had returned to their pre-SARS, their pre-COVID level of employment. The flip side is that means 25%, 26% had not. And if you look down below, 17% had not returned to work at all. And we can imagine these patients whose physical health at 12 months was actually, for most of them, pretty good. The driving factor here was probably emotional health. Not just for the patients, but how about their caregivers? So 17% were unemployed at 1 year follow-up, but caregivers were 1.6 standard deviations below normal on the mental health component of the symptom factor 36. This creates a toll on everyone. Anyone that's ever had a family member die of cancer, anyone that's ever had a child with, special health needs, anyone that's ever had to be a caregiver for somebody going through difficult times, it's not just the impact on the patient, it's the impact on the unit that's taking care of them. So I think when we think about designing our mental health care systems, for me and ADHD, it's not just a child, it's the parent that takes care of the child, and that parent may have their own set of vulnerabilities. And so you think about that family system dynamic about which we're going to need to kind of come through this. This came out just recently, whole different set of studies, and they said, how about the impact on parents of children who were hospitalized before and after COVID? So this is a study done over, once again, in Asia. And they said, it's tough for any parent to have your kid be hospitalized in a pediatric hospital. So St. Louis Children's Hospital, the Children's Hospital at Harvard, the Children's Hospital in Topeka, Kansas, whatever your hospital is, it's tough to have a kid in the hospital. They said, what's the impact of having a kid hospitalized now with COVID going on? And these are not COVID positive kids. These were just kids hospitalized during the COVID pandemic. And the emotional impact on a parent compared to if your kid had been hospitalized 6 months earlier. And we see the parents had twice the levels of significant anxiety disorders. The parents had 70% higher levels of depression. The parents had 50% higher levels of dream anxiety, which is really a PTSD equivalent. I wake up in the middle of the night with flashbacks and I can't keep doing it. And the symptom factor 36 was 69 points worse for parents with kids hospitalized during the pandemic versus parents who had had kids hospitalized 6 months before the pandemic. So the impact of, imagine now, it's not me being a caregiver. This is me with a child who had to be hospitalized for any type of physical health issue during this. Okay, so those are some of the challenges. I'm now going to shift over to what I think are some of the, hopefully, the solutions or thoughts or maybe, options as far as things we can do to help. So this is a study that came out very early. It was published in the American Psychological Association about a psychologist who is a pandemic specialist. He works at University of Nebraska, which is the United States Pandemic Specialty Treatment Center in the entire country. So they get the people in the bubbles that come in with terrible contagions. So they had the first 24 cases of really bad COVID that came in. They brought them to University of Nebraska. They brought them in bubbles. They medevac them, all of those types of things. And so what they knew from prior pandemics, such as SARS and other infectious outbreaks, is that it wasn't just the physical impact, it was the emotional impact. And a lot of these people gave up. They were in isolation. They developed terrible depression. They went on later to have suicide. He said, what can we do to mitigate against this? So this psychologist, and I have the author here, it's a lovely paper to read. He said, what if I do ways to help increase connection for people who are in isolation? What if I do ways for people to help themselves, but not only help themselves, but to help others by offering advice, by giving recommendations, by giving counseling to people who are in the same situation? So he decided that every day he was going to start with a virtual town hall for these people that were stuck in their bubbles within the University of Nebraska Pandemic Center. So they start every day for an hour, and they start with, what did we say was empowering? They start with accurate information. Here's where we are with the infection. Here's what we know to date. Here's what the data tells us, just very factual. It wasn't social media, it was practical data. Here's things we know that helps. He then said, okay, let's share with each other ways that you've helped to get through being in isolation, being in containment. Tell me things you've found. And somebody says, well, I've been reaching out with Zoom platforms to have a virtual dinner with my family every night. Somebody else says, I picked up art. I hadn't done art in 20 years. Somebody else said, I had somebody bring me a violin. I hadn't played the violin since I was in high school. Somebody else said, I've picked up reading books, some books I've been wanting to read. They helped each other. And what they found is helping others, there's nothing that's more healing for yourself than reaching out and helping someone else. And then at the end of each town hall, they spent 15 minutes with some form of mindfulness. So they talked about grounding, where I vision 5 things that I can see in my mind. I hear 4 things that I can hear in my brain. I touch 3 things that I can touch to give me peace. I smell 2 smells that bring me peace and happiness and joy in my life. And I taste 1 thing in my mouth that brings me joy and connects me with those I love. And they would have some kind of guided visual meditation, mindfulness exercise. And what they found is it dramatically decreased the negative social impact, the negative emotional impact of being in quarantine. The reason I bring this up is for the last 6 weeks, every morning in my clinic, we've started with a town hall. We start every morning at 9 o'clock. How is everyone doing? Tell me about your home life. Tell me about your family life. Tell me about yourselves. How are we doing? And we've had some of my staff say, I'm angry. I'm angry. The hospital next door to us that's had 26 staff members right outside our door test positive and a number of patients, they weren't honest with us. I said, I agree. They should have been honest. We're all going to be honest here. Somebody else said, well, I'm worried about my kids. What if I test positive here at the office, come take care of patients by bringing home to my kids? I said, that's a reasonable concern. Let's talk about that. And so we walk through each of those things. We do it every day. And then we share a story from a patient about where we've made a difference. So this virtual town hall connectedness, having a sense of purpose, it's been one of my take-homes during this pandemic that I'm going to do from this point forward in our clinic. I think it's just a great practice, but especially during periods of stress. Psychiatric Times had a great article. I'd like to reach each of you to reach out there. This is the link if you tap on it on your slide. But anyway, it's a slide on ADHD and telemedicine. It's our topic on Thursday. David and I are going to be talking about specifically diving into telemedicine, all the different platforms. How do you pick and choose? But physicians are now exempt from the restrictions by the Ryan-Haight Act. For anybody who doesn't know that, the Ryan-Haight Act came out in 2008. And there was an act that said, we want to be careful with this thing called the internet. We're not sure how it could access healthcare. We're not sure what physicians might do in a nefarious way to prescribe too many controlled substances. But what it said is a physician cannot prescribe a controlled substance without the first visit being a face-to-face visit. So essentially, it prohibited telemedicine being used for new evaluations for ADHD patients if you might need a stimulant. Given the COVID pandemic, in March, the government suspended the Ryan-Haight Act. We can now, through telemedicine, reach out and have an initial evaluation and prescribe whatever we think is the correct medicine for our patient. The next thing that happened is HIPAA requirements were waived. During the COVID pandemic, you can now use telemedicine portals such as FaceTime, such as Zoom, and up until now, we're not accountable. So HIPAA has been waived. My warning there is HIPAA is going to come back. So right now in the middle of a pandemic, you may use something that's non-HIPAA compliant, such as FaceTime. but get used to thinking about things that are HIPAA compliant for the long term. The other thing that happened is CMS, and I remember watching this in our news cam in our office. CMS came on in the middle of the day, and they said, we are now encouraging the use of telemedicine for anyone that needs it in the United States as a way to increase access to healthcare. And it is now 100% acceptable for all Medicare, Medicaid, or managed Medicaid policies. And we're instructing all the insurance companies also to reimburse for telemedicine on par with parity compared to face-to-face visits. And then finally, just recently, an 1135 waiver was issued. The 1135 waiver, which used to bog down telemedicine, was that you had to hold a license in any state that you saw a patient with telemedicine. They've now gotten rid of that restriction during the pandemic, as long as you have an equal and equivalent license for another state. So if I have a patient, I'm in Missouri, 25% of my patients are in Illinois, I can do a telemed visit right into somebody's home in Illinois. I can do a telemedicine into a group home in Illinois where my patient who has developmental disabilities plus ADHD lives. I can do a telemedicine into a nursing home. And I've done each of those. And so it allows you to do those types of things now with the restriction of that. I put this in for your benefit. CMS, the Centers for Medicare Services, which should give us our coding statuses, came up with the codes for Medicare that are given equivalent parity rating. This is once again our government, our president, and Centers of Medicare Services on March 17th. This is when the news briefing came out, when they authorized all of these restrictions be lifted from telemedicine. They now said these are the codes you can use, and they have to be compensated for any provider using telemedicine. Okay, let me walk you through. This is not our main talk tonight, but a few of the sites that we've used. I've never used telemed before. I've been negative about telemed. I like seeing my patients. We've adapted to 3 sites primarily, and one site is the majority of my patients. Doxie is a site that is HIPAA compliant. So if you go to Doxie, it's HIPAA compliant going forward. They have a free version of it that costs you nothing. They have another version where you can customize your waiting room. We have bought 8 of the clinics, 8 of the waiting rooms. What I like about this is you have a virtual waiting room. Your patient checks in. On the left-hand side, no one has checked in yet. I can see I have a patient queue of 1, 2, and 3 patients waiting for me. Right here on the right-hand side, you'll see the drop-down box. I can text message or email my patients an invitation to my waiting room. So if I have somebody who hasn't shown up yet, I text their number. It says, hey, Dr. Mattingly is waiting for you in his waiting room. Come on over. They just have to tap it. They don't need an app. They don't need a download. There's no waiting. Boom, they're sitting in your waiting room. So you can text it, you can email it, or you can send it to their calendar. I like the texting message. My patients tend to live in a text environment, especially my young people with ADHD. The other thing I love about Doxie is it allows you to share files back and forth. So I can share files back and forth very easily. I send them over an ADHD-RS. I send them over a PHQ-9. I send them over, I'll show you a little bit later, a thing that I developed on grounding, the visualization, thinking in your brain, seeing 5 things, hearing 4 things, touching 3 things. And I'll do that exercise with them right during a visit. Zoom is another popular waiting form. I'll have to say Zoom is not HIPAA compliant unless you upgrade and buy the 10 clinic version of it. So you have to have 10 waiting rooms, 10 clinicians using it for Zoom to be HIPAA compliant. So that's going to be a little more costly. The free Zoom is not HIPAA compliant, nor will it probably ever be, but you can use Zoom. And if I had to brag on Zoom, I think their visual quality is a little bit better than Doxie. Doxie right now is so overloaded that it sometimes snags a little bit on the visual quality. The other nice thing about Zoom, it's easy to have group talks. We've probably all had group meetings at this point. Negatives of Zoom, it's hard to text somebody an invitation. You have to email them the invitation. A lot of my patients don't check their emails. I like the fact that on Doxie, I can text them. Okay, let's dive into financial survival. So right now, there's something that I'm waiting for in my clinic. Our first round of funding, we didn't get it. The bank, we use US Bank. They closed up before they got to our account. I filed on day 1, but they, it closed it for us. We're waiting today to hear if we get funding. I'm hoping we will. So the payroll protection program, paycheck protection program, PPP, for any of us that have a small clinic, for any of us that own our own business, if you have an S corporation, a C corporation, you have an LLC, or you're an independent contractor, you can apply for it. The payroll protection program gives you automatically, if you apply for it, you get $10,000. That's part of it. You get to apply for the amount that is your average salaries from last year, so 2019, on a monthly basis. So if I say, what was my average monthly salary from last year, including all employees in your business, and for those employees that made over 100,000, maybe a psychologist, maybe a physician, you get to include them up to $100,000. You then get to take that monthly average salary and essentially multiply it by 2.5. It's 2 months plus 25% for each month, so it's 2.5. So 2.5 times your average annual salary, that's $1,000. It's forgivable as long as you meet certain requirements. What are the requirements you have to meet? I'll sum it up for you. Basically, by June 30th, you have to have your average payroll and your average number of employees back up to where they were last year. The goal of this plan is that you're going to rehire employees. You may have to lay them off. 50%, David and I were talking before this, 50% of clinics right now in the United States, their income is at least 50% or decreased from where they were. In St. Louis, many of our primary care clinics, because patients are afraid to come see them, over half have closed and are in temporary suspension. The PPP, to qualify to get the loan forgiveness of your 2.5 months of salary for employees, you have to rehire those employees by June 30th. So it's meant to be an incubator to rehire people, get people up and going. If you do not rehire your employees, you have to pay it back as a loan. What's the interest rate on your loan? It's 1%. So keep that in mind. It's a 1% interest rate. So, it's a low interest loan, but if you meet the criteria, it's a forgivable loan. Okay, this was an article that just came out just a handful of days ago. This was by the European group, a bunch of David and mine's colleagues over in Europe, where we know many of these practitioners, and it was published in Lancet Child and Adolescent Public Health. And they said, what are things that we think are guidelines? You can go to this link. They gave you guidelines about how to manage ADHD during the COVID pandemic. They do a lot of practical at-home tips for families. Keep things positive. Make sure all family members know what's expected. Build confidence and trust in your families. Help your child to follow instructions, promote better behavior, limit conflicts. And so my take-homes from this are structure is important. In the same way a school day is structured, our home life with our children should be structured. We get up at a certain time, we eat breakfast, and then we dive into a favorite class, do something fun. We work our way and chunk our way up to one of the more difficult classes, stick that about 10:30 or 11 in the day. We don't forget the importance of exercise. We don't forget the importance of modeling behavior to our children. Our children reflect back what they see with us. And I've told a lot of families, if you're running with your hair on fire, your kids are going to run around with your hair on fire. If you approach your kids calmly, with a sense of love, with a sense of affirmation, quite often you'll see your children reflect that back to you. When we think about at-home learning, we're in a new environment. And let me say to any of you that are interested in research, this is an area that I think is going to be fascinating. Because in the same way that after the Spanish flu in 1917, we followed mothers that became pregnant during the Spanish flu outbreak. And we looked at the risk of mental health issues like schizophrenia for a baby whose mother was infected. We've never had something like this that's not just a virus, but it's a change in our social fabric. And so during this COVID pandemic, schools are going to be closed for 6 to 8 months, the average school. So how does that affect slippage cognitively? How does that affect slippage emotionally? How does that affect slippage physically? There was a great article written on obesity talking about children gaining weight over the summer. And now we don't have a 2 to 3 month summer, we have a 6 to 8 month summer. What's going to happen to obesity rates in our country? So one of my tips is a daily structure with a check off list. One of my moms with ADHD, who has 2 kids with ADHD, she gave me this idea. She goes, instead of a checklist, I like a check off list where every time we do something, we give each other a high five, we have a little happy dance. So every subject we get through, every homeless thing, we do it in chunks, but we make those chunks a positive accomplishment. I thought, what a great way to twist. Instead of it being a duty and obligation, we make it a positive accomplishment. Start with the preferred subject and then schedule that hardest class around 10:30 for kids with ADHD, because concentration tends to peak around that time. So build with a positive affirmation in a winning class and then go to the other one. Positive reinforcement. Our kids with ADHD do not do well with negative reinforcement. Yelling at a kid, scolding a kid, taking things away from a kid with ADHD just tends to get more oppositional behavior. We know the rule of thumb is 5 to 1. 5 attaboys, I'm proud of you, I love you, look at what you did. To every 1, hey, come on, sit down, I got to set a limit with you. Exercise, 30 minutes a day, kick a ball, throw a pillow, do jumping jacks, watch a dance video. And then finally, model of behavior and mirror it. At-home learning. What do we know from prior studies? Studies have shown that lower socioeconomic and children with mental health issues tend to lose pace over the summer. And so what you find is during the school year, our kids with ADHD gain fairly closely to what kids without ADHD do. Kids from lower socioeconomic gain fairly closely. But over the summer, our children are at risk of backtracking, whereas kids without ADHD and kids from higher socioeconomic tend to continue to advance. And we know that that slippage isn't just a one-year slippage, it tends to be a cumulative slippage. So after 3 years, our kids with ADHD and our kids from lower socioeconomic backgrounds may not be a month or two behind their peers. Next thing you know, they're 6 months behind. So this is a period where we need to think about it. Down at the bottom, I included an article that just came out in JAMA Pediatrics. And it said, for healthy development's sake, it's time to mainstream summer. It's a wonderful article. It gives you inspiration about the importance of this year in particular. We need to get our kids engaged. We need them in enrichment programs. We need those enrichment programs to be virtual, to be online, to be with mentors, everything we can. We know these losses tend to be cumulative over the years. We know that children have increased weight gain over the summer, which tends to be cumulative. And we have no knowledge of what happens with a 6 to 8 month break. So this will be a cohort that will be followed going forward for the next 20 or 30 years. What's the effect socioeconomically? What's the effect for children with ADHD? What's the effect of children with ADHD who also come from a low socioeconomic class on the slippage, the downward trends, and then what can we do to help mitigate against that? Resources. These are just a lot of things I threw together. So this first one is from the Department of Education, Office of Special Education. It's a lovely site called parentcenterhub.org. They have a lot of tips. They have lectures. It's from the Department of Education. And one of the things I found, David, and I didn't know this existed until I started doing this virtual environment with my patients. They have lectures each and every day for our patients. They have lectures you can go into free of charge. Understanding parenting with families, concepts, strategies, action steps. They talk about primers for a Spanish population. We're all in this together. Communication and collaboration. You know, financially, what do we do for parents and caregivers with kids with special needs? You know, on and on and on. Each and every day, there's these lovely conferences you can hop on as a parent. You can bring a group of parents together. One of my moms said, you know, the group of us are watching these. We pick one a day to watch, and we watch them together to try to help increase our bonding, but also to give us strategies about how to help our kids. APSARD. You know, this conference is being sponsored both by ADHD in adults, also by AppSard.org. It's a group that David and I are part of. It's a group of clinicians, educators, researchers coming together. And we've increased the number of webinars we're doing. We've increased the number of blogs, social media presence to help give resources to clinicians during this time. I'd invite everybody who's not a member, join AppSard. I have a vested interest. I'm chairman of the membership committee, but it's a great organization where you can truly meet some of the great clinical minds, great academic minds, and make a lot of friends when you talk about getting through this together. There's another website that a group of us, there's 8 of us, have put together. It's a bunch of child psychiatry specialists, educators. It's a mom who's a nurse practitioner who has 2 kids with ADHD. It's a group of us put together called MoreDHT.com, and it has all kinds of videos. It has links to these other resources. And here's one of the examples where you can pop down each of these: setting daily routines, managing distractions, setting clear expectations, modeling your behavior. And they talk about what you can do to help your children have a better outcome with this. So that's free, it's downloadable, you can look at it. Here's a resource I send to all of my patients. So David, this has been something I've done with every patient pretty much universally since COVID has come out. I send this over to them while I'm doing a telemedicine visit. I said, I want you to do something every day called grounding. I do this in the middle of the night now. If I wake up and I can't fall asleep because things are on my mind, I'm thinking about my practice, something about a patient, I'll do something that's been known for a long time called grounding. It's essentially a form of meditation or mindfulness. And I'll say, listen, you start with 5 things you can see. And I want you to have those images in your mind. So think of a beautiful sunset. Think of walking hand in hand with your kids. Think of your house covered in snow. But you put each of those images in your mind and you pause to think about them. You then think of 4 things you can hear: the sound of rain, the sound of a thunderclap, the sound of the fan in the background. 3 things you can touch: the touch of your sheets, the touch of holding someone's hand, the touch of the shower. 2 things you can smell: For me, my two smells, and they tend to, all my other images change, my two smells is the smell of the air right before it rains and the smell of coffee when I'm waking up in the morning, and then one thing you can taste. But this whole exercise for people when we're pinging with too much social media, we're pinging with too much stress, helps to bring you back into yourself. And so these types of exercises, telemedicine, I'd never done this before. Telemedicine has allowed me to do this with my patients. I send them this, they download it during the middle of the session, we practice together, and then the next session, we're able to talk about it. So supporting healthcare workforce during COVID. Here's a study that was published in JAMA and said, what can we do to help our clinics, help ourselves in our clinics? Transparent and thoughtful communication contributes to a sense of trust and control. Places where they're not being honest with their coworkers, not being honest with their staff, the staff picks up on it, they start calling in sick, they don't want to come in, they feel demoralized. Ensuring adequate rest. So attend to the personal needs of both healthcare professionals and as individuals. Are you getting enough rest here at work? Go take a walk, get outside, go for a walk outside. How are you doing at home? Liberating team members from other tasks to focus on what's really needed. So one of the examples in our workspace, we talked about, what could we do that was better? And one of my therapists in my office, she goes, well, the waiting room is kind of an incubator. What if we let people sit in their car and we'll text them when it's time for their visit? We're seeing most of our patients through telemedicine, but we still have, I had to give 2 long-acting injectable antipsychotic shots. We have a couple of people in studies. We have people getting esketamine and other treatments. Some of our patients still have to come to the office, but we now let them be in their car in their own private space. We text them when it's time for them to walk in the office. With our staff, we've been providing lunch. So we pay for lunch every day since COVID has come out the last 6 weeks. We let staff take turns ordering. We have some things that we want to do to make sure it's safe as far as the food we're bringing, rest breaks, decompensation, and then once again, that daily town hall. And I think the daily town hall has been one of the most positive things we've done for our staff. Mental health for mental health employees. First of all, mental health employees are essential healthcare workers. We are just as vital as somebody in an emergency room. We're just as vital as an internal medicine doctor, a pulmonary doctor. We are needed. We'll likely face increased personal and professional stress coming to work, being exposed to each other. That's going to create stress within your office. We may be exposed to COVID. Our mental health hospital had COVID. We have had nobody in our clinic test positive, but the hospital right outside of our double doors has had 8 patients and 25 staff at this point test positive. We should wear masks and take personal hygiene. First of all, physically, that keeps, as one of my billing secretaries said, I said, so what's the importance of masks? And she goes, it keeps your cooties with you. That's exactly right. But in this day and age, it does that. But the other thing it does is it creates a sense of emotional calm. You know you're doing things to help master your environment. And then finally, something that's come up. When are you required to quarantine if you're a mental health employee? You're not required to quarantine because you've come in contact with somebody. We're healthcare workers. They expect we may have come in contact with somebody. We're not required to quarantine if a family member potentially has it. What you are required to do is to quarantine if you have any symptoms of COVID. If you feel like you're personally at risk, you don't feel right, you have a cough, you have a fever, you're tired, you're having aches and pains, you should quarantine until you have a period where you know you feel okay. And if you've had a confirmed test, you should quarantine. So we are essential healthcare employees. So pandemic take-homes. Mental health needs will increase among our patients over the next 3 months, 6 months, 9 months, not just among our patients, but among their family members, among our healthcare workers, among our colleagues, and among their caregivers. Mental health care will probably be even more necessary than physical health care when you talk about follow-up appointments. So developing systems, get your social workers, your therapists, your physicians, your nurse practitioners geared up for this, and think about how you integrate with those in primary care. Excessive social media use has been shown to trigger anxiety and hyperarousal and 20-fold increased rates of secondary decompensating depression. Adequate information, taking health precautions, sense of community has been shown to decrease emotional distress. And then finally, what do I think of the changes? What are the take-homes? We are going to change the way we give healthcare. We're going to change the way we educate. From this point forward, I know for myself, we're going to use virtual classrooms. We've learned how to reach out and educate in a way that we hadn't really thought of before. We've done it partially, but not really. Online learning. Our patients are doing it. We're going to be doing it. Many conferences are going to online learning platforms for the upcoming year. The European Psychiatric Association just announced this summer, instead of having a live meeting, they're going to have a virtual meeting. Some of our friends in Harvard, some of our friends in New York have already gone to virtual learning platforms, and they've had very good response if you do it right. And then virtual meetings. How do we have a meeting with a group of colleagues and share information, share ideas? I'm going to be in one tomorrow, for example. Telepsychiatry is here to stay. If you join us Thursday night, I'm going to dive into telepsychiatry. But I can tell you, I'm going to use it 2 weeks into all of my kids that go away to college. I'm going to have a follow-up visit with every kid that goes to university for the first semester, 2 weeks in, to make sure they're managing getting started at university on a good footing. It's a place that a lot of my kids have been at risk. I now have a way to bridge that gap. And then finally, e-medicine. Not only is it telepsychiatry, but it's e-medicine using rating scales. Your patients can do digital versions of rating scales. They can do digital blood pressure cuffs that give you blood pressure measuring. All of those things are going to be part of e-medicine, telepsychiatry for the future. So let me open at this point. If we have any questions, David, if you think of anything that's kind of coming in your mind, let's open up to the audience at this point. And thank you guys for joining us.
Thank you, Craig. That was just exceptional in the review. And it's often nice to see the research that's been developed from previous pandemics and follow up in the mental health arena, not only for first responders and the healthcare professionals, but also for the patients and the family members as well. We often experience these crises as a unique experience. And yet, if you look at crises, there's a predictable pattern of what happens in regards to psychological reaction and then the aftermath. So I think it's nice to have you laid out such a pattern to anticipate the needs. And that way crises aren't crises if you have a plan to anticipate the resources and the needs of the general population and the healthcare professionals as well. I might start off by asking a question about the severe risks. We're undergoing a tremendous financial strain for everyone, not only psychologically, but socially, but the financial strain for a great many people is severe and may get more severe. Those people with coexisting anxiety and depression, I wonder if you might just speak to the risks of suicide and assessment of that kind of risk.
Yeah, so I have a good colleague and partner from up in Canada who has an article submitted right now on the increased risk of suicide following the COVID pandemic. And you can imagine all the risk factors. If you say, what do you want to do to decrease suicide? Do you want to have increased connection? You want to have success? You want to have, all these different things. All of that's been taken away from a lot of our patients. Many of our patients have become isolated. We know that liquor sales have increased 40 to 50% during the pandemic. We know that, even though we're supposed to physically isolate, the downside is many of our patients emotionally are isolating. And then you think about as you said, the economic impact. You live in the area on the East Coast corridor where economic downturns, and here in Missouri, unemployment drive addiction, drive suicide, drive hopelessness, drive marital divorce. All of those issues, I think, things that we have to watch for. I did a radio interview today, David, and you would love this, and I hadn't thought of it, but they described getting used to COVID as the stages of grieving. And they said in the same way that patients, when they're grieving, at first it may be denial, it may be shock and denial, and then it may be bargaining. Maybe if I do this, I won't get it, or my family won't. And then there's anger. I'm angry at the government, I'm angry at my neighbors, I'm angry at the other countries, I'm angry at, whatever it is. But then it comes to acceptance. And then I would add one last stage to this, beyond the stages of grieving. Beyond acceptance becomes resilience. When I think about how do our patients kind of go through those steps, and I think that's part of the steps we see each of our patients go through. I think we all have been there. We go through periods where, this isn't going to affect me in St. Louis. I don't live in New York. Denial. This goes through bargaining. Maybe if I just interact a little less with people, but I can still interact with some people, I'll be fine. Maybe it's denial. I just don't believe it. This is made up. It's on media. I don't believe it. It's some outside made up force. I'm mad. I'm angry. F you, forget this. But then finally, acceptance. One of my patients, and David, I think you'll love this quote. It's a young man I take care of who has ADHD and Asperger's. I wasn't sure he'd ever get through high school. He got through high school. He got through college. He works as an activity therapist in a nursing home. And I had a telemed visit with him a few weeks ago, right when the pandemic was really hitting hard. And his clients in his nursing home were all in lockdown. They hadn't seen family members in weeks. But this young man was going around with iPads, connecting the family members with little tele sessions where they'd have dinner with a family member. He had games. He would just go around and boost their spirits. And I said, your job has never been more important. You'd be so proud. And this young man, he goes, Dr. Mattingly, he goes, you are right. He goes, I've learned something. He goes, in this day and age, you have to be safe. But to be safe, you have to be smart. And to be smart, you have to not panic.
True.
And I thought, out of the mouth of a young kid with Asperger's and ADHD, you have to be safe, but you have to be smart. To be smart, you have to not panic.
Well, I did want to highlight what Greg said, and I echo it as well, and that is we're often given behavior and logistical techniques to handle this. But I think, and I'm very much a pattern person, and I think the reaction in crises is very much the grief stages. And if you say, well, okay, that's pretty self-evident, when you present the pattern to the patient and say, you're going to go through this phase, and the next phase is going to be this, and then we're going to go through this, and each stage is predictable. We know we're going to walk through this. This is the psychological reaction. It objectifies it, it normalizes, and gives it a predictability. And the absence of chaos really settles down anxiety and panic.
I agree. Knowledge is power. That's perfectly said. That's exactly right, David.
So if I can ask the question, Greg, you mentioned before the concern about obesity in children, but there's been a tremendous amount of joking in social media about being, stuck at home and that refrigerator is just there. And people are really concerned about gaining weight during this time. There's even been a cartoon where there's a couple that want to leave their home, but they can't because they've gained too much weight. They can't get out the door. I'm wondering if maybe both of you could speak to the idea of handling your anxiety by eating and how we might be able to come up with alternatives for that.
Well, I think this is a good segue into the need to maintain your medication. If you have ADHD, and this is sponsored by ADHD in adults and Appsard, we do want to focus on the population of patients who have ADHD. Now, often people at home, when they get the stay-at-home order, they say, hey, we got a couple of snow days, and they take great liberties with their schedule and their eating pattern. And they may even decide, look, I don't really need to be on the medicine because I don't have much to do today. And that results in an increase in appetite and then an increase in anxiety. And that deteriorates into opening the refrigerator and checking out what's left from the leftovers. So I really tell people, look, when you're at home on stay-at-home orders, you need to take your medication on a regular basis. That's not only going to maintain your cognitive ability, your emotional ability, but it's going to keep your appetite in check so you don't start overeating.
Yeah, even more simply, maybe, when do our patients with ADHD, when they're under stress, do better without their medicine? Stressful times are times when probably being on the right medicine, having your brain functioning as well as possible is more important than any other time for all of our patients. So I 100% agree.
I've also told patients that you now have time to do that which you had hot on the list, that if I had the time to do, this is what I would do. Well, you now have the time to do that. So go for that walk if you live in a neighborhood where you're safe and you can put on a mask and not be around people. Go out for a brisk walk for 30 minutes or 40 minutes. Strap in with your earpods and headphones and listen to a webcast. Learn something new that you previously would not have learned. I was recently turned on to a magnificent celloist whose music is just phenomenally calming and relaxing. I would not have discovered that if I was not at home working and floating around on the internet.
Yeah, I would agree. Take this time to connect with your office, your clinic, yourself, your family. During this pandemic, I've played more ping pong. I've thrown more footballs. I've watched more movies with my family than I have in the last many years. So you take time to enjoy those things and kind of cherish the things that maybe, you'd forgotten to cherish.
I wonder if we could get back to some risks. I'm terribly concerned about rural America and the impact that it's having on rural America, especially with the presence of firearms. You mentioned the increase in alcohol purchases since the pandemic started, but there's also been a run on firearm purchases. I wonder if you could just speak to the issue of safety, firearms, comorbid depression, ADHD, impulsivity, and maybe you could put that in a nice package. I know I gave you a very complex question, but you're good for it.
No, I think you're 100% right. Let's go back to the data from the pandemic in Toronto. If you look at that Toronto, a year later, 25% of people were not back to their normal level of, employment. 17% were 100% unemployed. Imagine the emotional impact in that population. Now let's throw in some alcohol. Let's throw in financial despair. Let's throw in ADHD with impulsivity. Let's throw in a couple of firearms laying around the house. We can all predict what the outcomes will be. And those are going to be our challenges for the next few years. The good news is there's a lot of things we can do to help. There's tons of things we can do to help, but those are the challenges we have to overcome.
We might want to advise primary care physicians and practitioners in general to make assessments of firearm presence in the households of patients who might be unstable emotionally or destabilized in the midst of continuing overwhelming stressor.
We've got a question here, guys, from Randy, who's asking, what are the implications for clinical research visits and pharmaceutical product education going forward?
Greg, you do a lot of trials. What impact has this had on subject recruitment, subject exam, and ongoing research?
It's a great question. So, there's a lot of emphasis these days on research, but it's mainly around, viral treatments and things of that nature. Most clinical trials in the mental health field have halted enrollment of new patients during the COVID pandemic just because of concerns about follow-up consistency. For any patient that is in an ongoing trial, we've continued to see them. Some of those visits have been virtual, some of them have been physical. We have people in a recurrent depression trial, we have an adult ADHD trial, we have a schizophrenia trial. And so we're taking care of patients in all of those populations. You try to do it safely. We ask our patients to wear masks. If they've had any signs or symptoms of a major flu or fevers, we ask them to call ahead of time. But once again, mental health people we're essential healthcare workers. What I do predict though, and David, I'll say this, I think that research is going to explode as far as the number of trials and research options after this. I think the good news is this has funneled America's interest in providing better healthcare. And so I think that is only going to escalate after we come out of this. The next few months are going to be really challenging, but I think 6 months from now, there's going to be even more research across the board, including mental health, and especially as they start seeing the mental health issues involved in the patients that are dealing with the pandemic.
So with the use of telemedicine and with the waivers that you so clearly cited that allows greater flexibility of clinicians to use telemedicine, how do you anticipate this will play out in the future? Because some of these waivers have now facilitated an increased access of people to mental health professionals. And I anticipate that patients will want to continue along this line. And how do you think this is going to evolve? Because we're not going to go back to how things were.
I think you just gave us a segue to Thursday night's talk we're going to be doing, David. So telepsychiatry will be here to stay. And I was a skeptic up until now. So I think telepsychiatry, and I envision myself in a hybrid practice. I'll probably see more patients live and in the office, but I'll see a group of patients with telepsychiatry from here on out. Whether it's bridging a gap, whether it's bridging a transition, whether it's a patient in a group home, whether it's a patient who's at college, who's moved, a kid who's spending the summer with a parent. I think telepsychiatry is here to stay. And so I think, that is going to be a part of our practices. And I think, when you talk about, what are the innovations we've learned from this? Telemedicine, telepsychiatry, it's going to be a good thing. And David, one of the things I've learned, you can reach in and have a televisit very quickly for 5 minutes with somebody and check and see how they're doing. That was hard to do with them driving across the town to come see you and they have to take a half day off work. I can reach in and say, listen, I'm worried about you. Why don't we touch base next week for just a few minutes? I'll have a 5-minute quick visit. And there's codes that allow you to do that. You can bill for it. You can be reimbursed for it. And it's great for the outcomes of our patients.
Let me jump in with a question that's been asked that builds on that, Greg. Casey's asking, what about for people who are home alone? And I think the question is, there's not a lot of social contact, they're isolating, and what recommendations do we have for, working and helping people who are isolated by themselves?
I think digital devices and digital, it's not the same as holding someone's hand. It's not. but it can be awfully good. I have done more therapy in the last 2 months as a clinician than I've probably done in the last 10 years. I've spent a lot of time reaching out to people, talking, inspiring hope, bonding, doing grounding, working on affirmations, structure. My favorite visit, this is a young boy with ADHD who has a lot of anxiety. David, he comes in his office, my office with him. He hides behind his mom's chair because he has such bad anxiety. I had a visit 2 weeks with him. And when we got there, Mom said, Ross is in a fort. I'm not sure he's going to come out. And I look and I see this big fort built in the family room. It's got chairs and blankets and things all over. And I see Ross kind of peering out. He's kind of shyly looking at me. I said, well, let me go talk to Ross in his fort. Mom stuck her computer or laptop in the fort. I go, Ross, tell me about your fort. I love forts. I used to build forts as a kid. He shows me around. He's showing me the camera. He's showing me how he built this chair. Then we talked about emotions. We talked about frustration. We talked about how when he first started being off school, he did well, but the last couple of days he hadn't handled it so well. We talked about holding the thought in his brain long enough to deal with his thought instead of an emotion. It was the best session I've had in the last month with any patient. And so my take home out of COVID is going to be my session in the fort, my therapy session with a child I'm taking care of in a fort. So everyone out there, join us Thursday. We're going to have a great session, and we're really going to dive into telepsychiatry and talk about different platforms, what we've seen as pros and cons, where you can use it, how do we adapt it going forward for our patients.
Great. So, David, do you have a last thing to say? Because I want to close it up.
Well, so I did want to take the opportunity to mention CHAD. CHAD is Children and Adults with ADHD Association. They have support groups around the country. However, under COVID, they are doing virtual support groups. And so if you go to the National CHAD website, chadd.org, you'll be able to find the support groups and see if you can check into a virtual support group for ADHD. And again, for the person who's sitting at home, finding these group supports is very important. So if the person has ADHD and wants to participate in that, look up CHAD. I just want to thank Greg for putting together this slide deck, looking up the latest research. As you saw, some of these publications were just probably within the last couple of weeks. So you got the state of the art and the comparison to previous pandemics. Hopefully everybody's learned something. I know that I certainly have. I thought it was excellent, Greg. Thank you so much. And I'm going to turn it back to you to sign out and give everybody a good night.
Thank you for joining us. Have a great evening.
Great, everybody. Thank you. A big thank you to Greg Mattingly, MD from Washington University School of Medicine, and David Goodman, MD from the Johns Hopkins University School of Medicine. Wonderful presentation and conversation. We will be getting back with you again this Thursday night to talk about telemedicine and telepsychiatry. And this is Jonathan Marks with ADHDandadults.com, and this has been co-sponsored by APSARD, the American Professional Society of ADHD and Related Disorders, and ADHDandadults.com. Thanks so much for being here. We'll talk to you soon. Take care, everybody.